Now the next speaker is Dr. Rashmi HD, MBBS from AIMS BG Nagar, best outgoing student of the batch, MD from MMCRI Mysore. Professional experience serving in the field of anesthesiology and ICU from past 9 years. Worked as an assistant professor in AIMS BG Nagar and HIMS Hassan for 6 years. Present designation Associate Professor in Department of Anesthesiology, Hassan Institute of Medical Science, Hassan. Recognized PG teacher since 2022. Interests and achievements. Past treasurer of ISA Hassan for 5 years, conducted numerous CMEs and workshops. Master trainer for ECLS Jeeva Raksha program conducted by RGUHS. Special interest in ultrasound guided regional blocks. Awards and publications: had secured second place in paper presentation in South Zone Conference held at Belagavi in 2016. More than 10 publications in national and international journals. Over to you, madam.
Thank you, sir. Thank you for the warm introduction. Good morning, all. I'll be dealing with positioning anesthesia in the next few minutes. So this is an overview of my presentation. I'll be going through the goals of proper positioning, commonly adopted positions, physiological alterations, precautions, complications and its prevention, and the repositioning checklist. So coming to the goals of proper positioning being the best surgical access and to minimize the potential risk to the patient, and also to maintain the homeostasis of all the systems. So what are the requirements we need for this? A proper planning and a good communication between an anesthetist and a surgeon, and number of skilled personnel should be more at the beginning, at the end of the surgical procedure for facilitating the safe positioning. So commonly adopted positions, as we all know, this is supine, lithotomy, lateral, prone and sitting. This is supine position, also called dorsal decubitus position. It's the most common position we are using in our anesthesia practice. And what are the physiological alterations we expect in CVS, that is cardiovascular system? As soon as the patient goes to supine position, there will be increased venous return, that in turn increases the cardiac output and increase the blood pressure. That will be well tolerated in a normal individuals, except in obese and pregnant patients where you can expect hypotension because of aortic valve compression. And in respiratory system, as soon as the patient goes to supine, there will be increased movement, increased cephalic displacement of the diaphragm, and there will be increased closing capacity that in turn leads to increased atelectasis and increased shunt. So what are the precautions as an anesthetist I will take when a patient is put in supine? As soon as the patient is put in supine position, the arms we need to take care, it should be either tucked to the side or it should be abducted to less than 90 degrees in order to prevent brachial plexus injury, and the hand and the forearm should be either supinated or it should be kept in a neutral position. So coming to the variations, we have 4 variations in supine position. These are lawn chair, frog leg, Trendelenburg and reverse Trendelenburg. Coming to lawn chair, it's almost same as supine except the hips and the knees are slightly flexed. So it is better than supine position because the tension on the ventral abdominal muscles and the back is released. So venous drainage will be little better. So next is this frog leg position, wherein the feet of the patient are kept together, and this is better for the surgeries of perirectal and anal regions. And coming to most common position, that is Trendelenburg or head and down position, where we give head and down of 15 to 20 degrees. So what are the uses? In order to increase the venous return in hypotension, in order to prevent the hair embolism, and in order to increase the distension of the vein during central venous catheterization. And nowadays, robotic, prosthetic and gynecological surgeries, we use 30 to 45 degrees of Trendelenburg position. And what are the physiological alterations? There will be auto transfusion from the lower extremities. So, but it returns to normal within 10 minutes. And also in the respiratory system, FRC is decreased. So if the patient is breathing spontaneously, the patient work of breathing will increase. And if the patient is under general anesthesia, there will be increased airway pressure. So we need to modify the ventilatory settings when the patient is put in Trendelenburg position. And in CNS, we can expect increase in intracranial and intraocular pressures. What are the concerns if I am putting a patient in Trendelenburg? So if there is a prolonged surgery, there will be upper airway obstruction. So secure the airway with endotracheal tube, and prevention of the fall by restraining the patients by using the beanbag support or the shoulder braces. So reverse tendon arbor, or again it's a head up position. It is used in laparoscopic and upper abdominal surgeries. So what are the complications? So I told you, so brachial plexus injury is the most common nerve injury, followed by ulnar nerve injury. And pressure alopecia you can expect wherever the pressure is put on the dependent regions like occiput, olecranon, pelvic and heel regions, and back pain due to loss of the normal lumbar lordotic curvature. Then coming to lithotomy positions, as we all know, the uses are being in urological, rectal and gynecological surgeries. Hips are being flexed at 80 to 100 degree from the trunk and legs abducted at 30 to 45 degree, and leg is supported with the supports and foot section of the table is removed. So these are the variations: low lithotomy, standard and high lithotomy positions. And what are the stirrups you use? So we use different types of stirrups like knee crutch, candy cane and boot type. Again you can expect different nerve injuries. In knee crutch you can expect the peroneal nerve injury, in candy cane on distal nerve and distal sural and plantar nerves, and boot type is more better than these two. So what are the complications you can expect? So always while putting the patient in lithotomy position, put both the legs simultaneously in order to prevent injury to the lumbar spine, and hands should be taken care, it can get crushed when the foot end of the table is raised, and also rarely you can expect compartment syndrome when the surgery is taking place for more than 2 to 3 hours. So as an anesthetist, I need to lower the legs periodically when the surgery is more than 2 to 3 hours. And these are the different nerve injuries. So saphenous nerve, it is pressed over the medial corner of tibia, peroneal nerve at the lateral end of fibula, and femoral nerve and obturator nerve at the thigh flexion. And this is lateral decubitus position in order to decrease the, so where it is commonly used in hip surgeries and in the surgeries of thorax and retroperitoneum. So dependent leg is flexed to decrease the stretching of the lower limb nerves, and torso is supported both anteriorly and posteriorly. Whenever the kidney rest is used, it should be placed under the iliac crest. So dependent arm and the non-dependent arm both should be padded, and I should press on this, that is axillary roll. It is a misnomer that the axilla should be free. Axillary roll should be placed between the chest wall and the table, caudal to the dependent axilla, in order to prevent the compression of the neurovascular bundles. So coming to prone position, also called ventral decubitus position, used in posterior fossa skull surgeries, posterior spine, buttock and perirectal surgeries. So CVS is well maintained. RS actually respiratory system, it is pulmonary function is better. That is the term we use prone ventilation in ARDS patients. So what are the concerns? So as soon as the patient is making you put in a prone position, ET tube should be disconnected, monitors and line disconnected, ventilation and monitoring, it should be re-established immediately after prone position, and head is kept in neutral position. And what are the various aids we use in prone position? This is for the head and neck support. This is the silicone gel headrest, and this is the Mayfield horseshoe headrest we use. And nowadays we are using foam head cushion. Along with that, we can see in the second diagram we are using the mirror system, so that in order to prevent the compression of the eyes and the vital structures. For support of the torso, we are using horizontal foam bolsters, and this is the preformed table frames. This is the Wilson frame and the Andrews frame. And what are the complications? So most importantly, as an anesthetic, I should make the abdomen free so that there will be decreased bleeding during surgery, and supraorbital nerve, ulnar nerve can get compressed, so you should be padded. And most importantly, eyes should be adequately padded, because if there is any vision loss, it is the anesthetist's responsibility. It is going to take it. And swelling of the tongue, we have to prevent it by avoiding the excessive flexion of the neck. And coming to last position, that is sitting position. So surgeries of the posterior cervical spine and shoulder surgeries, there will be flexion at the torso with less than 90 degree hip flexion, and knees are slightly flexed. Head is fixed with rigid pins and taped into headrest. So slight variation of sitting is your beach chair position, wherein the sitting position with the reclining head. It is most commonly used for shoulder position, shoulder surgeries. So main thing we are concerned is blood pressure measurement. So blood pressure to the brain will be 15 to 20 mm lower what is being detected in the arm. So we should maintain the blood pressure more than 70 mm Hg of mean arterial pressure. So what is the most dreaded complication we are feared of? It is venous air embolism because of negative pressures due to opening of the dural venous sinuses. So if it is small, can be detected only by TE, that is transesophageal echocardiography. And if it is medium, it can be noticed clinically. How? Because of increased heart rate and increased blood pressure and decreased EtCO2. If it is massive or large, that is more than 50 ml, it is catastrophic. Okay, you need to tell the surgeon to stop the surgery and you need to proceed with the resuscitation. And if there is a patent foramen overlay, it can cause paradoxical arterial embolism also. So what is the treatment for VAE? Tell the surgeons to stop the surgery, flood the surgical field with the normal saline, increase the FiO2 to 100%, and IV fluids and vasoactive agents should be given, and you can change the position to Trendelenburg also. And last but not the least, I want to emphasize on this very important repositioning checklist which I have got with some article. So it is according to ABCDE. Whenever a patient comes to OT, whenever a patient is given anesthesia, each patient case sheet should be attached with this repositioning checklist, so that whenever a patient position is changed, every anesthesia resident should tick this checklist so that there will be less complication to the patient. Okay. So this is A stands for airway. You need to check the endotracheal tube and the LMA whether it is patent and in correct position. And B stands for breathing. You need to check the ventilation, auscultation in both the axilla, and monitoring of capnography and SaO2. And C stands for circulation. We need to monitor the circulation by heart rate, BP and ECG. And intravascular lines, make sure they are all in situ, patent and accessible. And D stands for eyes and neurovascular. Make sure they are closed and protected and padded. And E stands for exposure. All cables, catheters and electrodes should be checked and removed from the patient or operating table interface while changing the position. Whenever a patient changes position, if you take this checklist, we can minimize as much as the potential risk to the patient. So my take-home message being, so patient positioning is a teamwork between the anesthetist and the surgeon, and patient positioning should be natural, as though patient is positioning in a awake and unsedated condition. And I suggest a mandatory repositioning checklist for all the anesthetized patients. And I thank you one and all. I thank all my teachers, guides and mentors. As an alumni of this college, I feel overwhelmed to stand here and present in front of you. Thank you.
And that's the nice presentation, Dr. Rashmi. I would just like to add a point to this. These days, regional anesthesia in prone position is an upcoming thing. So postgraduates can go through that. I would like to call upon the next speaker, Dr. Pooja Shah. Dr. Pooja Shah comes from my place, Shimoga. She is Associate Professor at Subhaya Institute of Medical Sciences, Shimoga. She has done her MBBS from SDM Medical College, Medical Sciences and Hospital, Dharwad, and MD Anesthesia from JNMC, Belagavi. Her interests are in TIVA, NORA, and regional anesthesia. She has been awarded the best paper at NDA-CON in 2012. Winner of debate competition during PGXL 2013. She is author of Residency Made Easy, Anesthesia, and she has 5 national and international publications to her credit. Over to you, ma'am.